Okay, so good morning, everybody. Happy New Year. Welcome back. 2021 is upon us, which I'm sure we're all relieved about and looking forward to. So we'll move on to our grand rounds today. It gives me great pleasure to introduce Dr. Jaggi Rao, who's going to be talking about skin manifestations of COVID-19. So just a little bit about Jaggi. Jaggi's a board certified dermatologist licensed in both Canada and in the United States. He has a very busy private practice and specializes in medical, aesthetic, and surgical dermatology. He is currently clinical professor of medicine and was a previous dermatology residency program director at the University of Alberta. He serves in many roles. He's founder and medical director for Consult Derm, a popular and successful teledermatology platform which helps physicians and patients across the country. And he's also created a telederm outreach, which is a philanthropic telehealth service to provide assistance to third world countries. Jaggi's an author, a peer reviewer, and associate editor for a number of prominent medical journals and has won numerous clinical leadership and academic awards, including the Canadian Dermatology Association Teaching Award of Excellence. So without further ado, I'd like to welcome Jaggi and hand it over to him. Thanks.
Thanks so much, Norman. I wanted to wish everybody a very happy new year and also to thank the Department of Medicine and Dr. Kassam for the invitation to speak here today. And also I wanted to thank you for the privilege to represent my division, Division of Dermatology. If you have any skin issues, skin, hair, or nails, we are definitely there to help you out. So don't hesitate to reach out to us. My practice is affiliated with the university, but I'm not actually at the university. I'm pretty close by at 109 Street and 76th Avenue. If you wish to, if you have any difficult patients, any challenging cases, even emergency cases, don't hesitate to reach out to us. We'd be happy to help you out. For those of you who wanted to have a presentation copy, I have created a QR code on the bottom right here. So don't hesitate to take out your phones and just focus your camera onto this QR code, and it will lead you to my Dropbox, and you can readily download the presentation handouts. We have about 11 pages of handouts, and I promise to go through it fairly quickly. Most of them are images, so I think you'll probably enjoy them. They'll be very efficient for you. Now, with respect to disclosures, I've had the privilege and pleasure of working with a number of different companies in the past couple of years, and they're all listed here. And I also, I'm the team lead for our Consult Derm teledermatology program or service. If anybody's interested in sending patients that way, that's another option to have some dermatology advice. I'm also the creator of and moderator for DermaCon, Day of Dermatology, which is a dermatology conference. I think it's now the largest dermatology conference to learners who are usually primary care physicians as well as pharmacists. So with that, I'll begin. Oh, I haven't received any payment or funding. This is something that I really wanted to do for you. But if you have any further questions or comments, don't hesitate to reach out to me anytime. I think there might be a short Q&A at the end of this presentation. So today we're going to talk about the skin and COVID-19. As you know, the skin is the largest organ, and as a result, there's a lot of different tissue types that are there. So not just with COVID infection, but a lot of infections and indeed internal medicine manifestations can show itself within the skin. And so we'll talk about this as it relates to COVID-19. And also, I wanted to show specifically for internists, how can you identify some of these different conditions, and hopefully you can identify it early enough and maybe even manage it before it gets out of hand. So with that, here's our infamous virus. And we talked about how it has dermatologic sequelae, and it certainly does. And often people miss this. They just say rash, but I'm going to show you specifically the different rashes that are associated with it. There's a whole skew of this. Some of it is actually well known and documented, and some of it isn't so documented. So I'll show you both the rare as well as the common manifestations, as well as things that you may not think about, like the rashes that we deal with even with the treatments that we offer, and perhaps even now with the vaccine, we're going to see different things. So it's an ongoing dynamic learning process, even for dermatologists. And if you see something that's weird and wonderful, please don't hesitate to let us know. we're learning just as you're learning as well. Also, with this, I'm going to try to present both common ways of treating this and common thoughts, but also show you my own opinions. So the opinions expressed are of course, those of mine, and they may not necessarily reflect all dermatologists, but I'll show you what has worked in my practice. I have a very busy practice, see about 60 people every day. So I've seen lots of complications and sequelae related to the skin for COVID-19, and I'll show you some things that have worked quite well. So with that, let's talk about classification. When you see a skin problem that's associated with the timing of COVID-19 infection, or even within this pandemic, you wonder, is it associated with this at all? And how do you wrap your mind around classifying this? And I'll give you a very practical way of doing that. Basically, I think of three different classification patterns. Is it truly a skin manifestation of primary COVID infection? Or is the skin problem related to PPE and personal hygiene measures? Or finally, is it related to COVID-19 management? Sometimes our intervention can sometimes also cause skin manifestations. So this is the way I like to consider dividing up these skin manifestations, and we'll hopefully go through each one by one. First, let's talk about the primary COVID infection skin manifestations. There's a few of them, and in fact, the list seems to be growing, but it is just like the curve itself, the pandemic curve, it seems to be plateauing. So initially, when we first saw skin manifestations, everybody's very excited. There's lots of case reports that were written. And then they created this registry. The American Academy of Dermatology created this registry at aad.org. And it started growing quite a bit, especially over last summer. And then it started plateauing around fall. And now when anything new happens, everybody's really tweaked, their curiosity's tweaked. And they also have information with respect to vaccine rashes too. So that's something that is an ongoing dynamic process. If you happen to see any manifestation, whether it's new or not, for you or not, it doesn't quite matter. Please feel free to access the registry, and you're going to help the global learning environment there. So if you go to that site, they'll actually show you this anatomic diagram, and in there they've constantly adding on to this. And as I mentioned, they haven't added on for a while, but these are the manifestations for primary COVID-19 infection that has been seen over the past few months, even up to a year. And you can see that they're quite varied. And what I thought I'd do is actually show you some pictures of how they look and maybe describe them, and then I'll show you how we can treat them. Most of them, of course, are self-resolving. If you did nothing, they would go away, but we do like to treat them just more for symptom relief and also just to allay any fears for the patient. So there's 6 major manifestations of COVID-19 primary infection, and they're listed here. So we have urticarial plaques. These look like hives on the top left. Then we have this acral ischemia, and it goes by various names. Some people have called it COVID toes or COVID feet, and indeed it can happen on the feet, but also on the hands. Then we have this classic morbilliform eruption, which looks very similar to a viral exanthem. They have seen this primarily in, this looks very similar to what you would see with dengue fever, which we don't see a lot of in North America, but it has this maculopapular appearance, and I'll show you some close-ups of this. It's actually one of the most common things that we'd see associated with primary infection of COVID. Then there's the vascular patterns, including livedo reticularis, and then we have a vesicular pattern, which looks like a chickenpox-like rash, and then we have a petechial or purpuric eruption. And I'm going to show you not only specific images of this, but where it lies on the spectrum of severity as well. So the way I kind of think about it, we talked about the skin being the largest organ and having many tissue types and over 2,000 unique skin conditions. The reason for that is because there's so many different types of tissues and different events that can occur within the skin. And the two ones that are related to COVID-19 are either inflammatory, which is immune mediated, or vascular. So vascular changes and inflammatory changes as it deals with the immune system can result in skin findings. And one of the ways to kind of wrap this around your mind is to think about it before symptoms, during symptoms, and after symptoms. So if we take those classic 6 findings that you saw there earlier in that chart and you put them into this form, this is what we'd see. So before the symptoms actually occur, you may have a vesicular eruption. I'll show you what that looks like and describe that. And then when patients are symptomatic, largely they will have one of these 4 or sometimes even overlapping skin patterns, the morbilliform, urticarial, livedoid, and petechial. And then after the symptoms have abated, sometimes they'll have other signs. For example, acral ischemia can happen before, during, but often we even see it after a symptomatic period of COVID-19 infection. So let's go through them one by one. The papullovesicular, this is the morbilliform eruption that we talked about during symptoms. Well, usually this happens in about 9% of cases. So how do we know this? Again, going back to registries such as the AAD, American Academy of Dermatology Registry, when they looked at over 500 plus cases, they found this to be in about 10% of cases. So 10% of people who are symptomatic or even before the symptoms occur will have this type of skin eruption. Usually it lasts for about a couple of weeks or less. And what we're seeing is small monomorphic vesicles or pseudo-vesicles on the trunk and extremities. So they almost look like little blisters underneath the surface of the skin. And this includes what we call erythema multiforme-like eruptions. So erythema multiforme, or EM, you might recall, is a skin pattern that often happens as a reaction to a virus. And usually it's respiratory viruses. Some people have even said HSV might be associated with it, but so can COVID-19 infections. And I'll show you an example of this. So if you see this, we call this papular urticaria. And you can see that it looks like it's filled with fluid. It looks like a blister. But in fact, if you went ahead and poked this, you wouldn't get a lot of fluid out. You might get a little bit of blood and perhaps a bit of interstitial fluid, but it's quite solid. And it almost looks like an insect bite or arthropod bite reaction because, of course, we're showing you the extremities here. You might even think of that as the differential diagnosis. But indeed, with this COVID-19 manifestation, we see it very widespread. So it can be on the trunk, it can be on the extremities, usually on both is what we'll see. And it can be grouped. So one of the other things you consider is this a herpes simplex virus infection or even a zoster infection? But typically it'll be asymptomatic, if not a little bit of itch associated with the inflammation that's there. So it's solid. It's not really vesicular. It's almost pseudo-vesicular. Pseudo means similar or fake vesicular. It's not really vesicular, but it looks like it. And we see multiple lesions like this. Now, this is very interesting. When you start to see these annular pseudo-vesicular lesions on the palms, we always think of erythema multiforme. So erythema, red, multiforme, many forms. One of the classic forms is these annular papules and plaques, and we often see this with viral infection or even preceding a symptomatic phase of a viral infection. Palms and soles are very commonly represented, as you see here. And so this is erythema multiforme, or EM-like. And if you combine this with those pseudo-vesicles elsewhere, then you can say that this is a reaction pattern to possibly a virus. And indeed, these patients were positive for COVID-19. Now, you take a look at this rash is also pseudo-vesicular in some areas, and other areas a little bit more purpuric. So all of these have occurred before any symptoms have happened, and this patient broke out with this rash. So literally the day before, they didn't really have this, and then the next day they started to develop these papules. They may also have some background seborrheic keratoses. We're not talking about those. We're talking about these inflammatory papules. They look a little bit vesicular and even purpuric at times. Now, when people see purpuric lesions, they always think, geez, this has got to be related to a vasculitis. In this case, it's not true. It just has to do with vascular dilatation. And sometimes you'll have extravasation of red blood cells, or even just the vascular dilatation itself can lead to the erythema and the purpura that you're seeing. But it isn't actually a vascular destructive process, and it is self-limited. It usually goes away within about 10 to 12 days. Here's another example of a pseudo-vesicular lesion. Again, this patient had manifested this before any of the symptoms associated with COVID-19. So totally asymptomatic. They can develop these lesions. Usually they're grouped. We mentioned on the trunk, but often on the extremities as well. And then after a while, they can actually become quite firm. So you see the differential diagnosis for this might even be molluscum contagiosum, or warts, from this kind of distance. And if you feel it, it wouldn't be warty at all. It's just smooth skin that's become edematous. So the interstitial fluid is indeed that. It's within the dermis of the skin. So if you tried to poke this with a needle, you wouldn't get much out. You get a little bit of blood, perhaps a bit of fluid, but it wouldn't be pure fluid that you would get from a blister. They're not actually blisters, they're below that plane. And if you take a look at patients, the dorsum of their hands often will be manifested because it's relatively thin skin compared to the palms and soles. Palms and soles, you'll get that erythema multiforme like picture, but on glabrous skin, that's what we call this type of skin, then you'll often see this pseudoedematous picture. Okay, so morbilliform eruption. So this is one that's really common during the symptomatic phase. The pseudo-vesicular is before the symptomatic phase and during the symptomatic phase. When they actually have symptoms, you will often see a morbilliform eruption. So how often? In about 50% of cases, according to the registry data. And it lasts for about a week, maybe a little bit more. Widespread maculopapular eruption morphology. You would even think, is this a drug eruption? Is it a viral exanthem? It looks like one of those types of rashes. You'll see sometimes perifollicular accentuation, so around hair follicles and pores. You might see little inflammatory papules, little dots. And often you'll have a bit of scaling if it lasts for more than a week. So why does that happen? Well, the skin is overturning at a faster rate, and then you'll have retention of scale at the surface. It may even involve itch, so pruritus. 50% of lesions are in fact pruritic, but notably this will spare the palms, the soles, and the mucosa. So literally it would look like a viral exanthem. Now, forgive me for the poor quality of this image. A lot of these images have been sent by teledermatology from other physicians in the community, and sometimes they're not totally in focus. But you know what? It's not good, but it's good enough for us to make a diagnosis and often to help out patients and to exclude things that are much more severe. So what we see is a scattered perifollicular eruption. This is a closer image, and you can see how we have this confluent erythema. Yes, it has different foci, especially around the pores here, but generally that erythema is confluent if it goes on for a longer period of time. Sometimes patients will feel warm, so if you touch this because of the vascular dilatation, there will be a warmth to that. You can see that there's a little bit of scaling in some areas, and that's not atypical either. Here's another example. Even in places that have pressure, you'll notice that there might be a bit more blanching. So don't let that throw you off. Look at bony prominences. Often the erythema will be more confluent along the site of an underlying bone. But generally speaking, it'll be confluent as time goes by. And then, just as it came, it will disappear. So it comes on rather suddenly within a couple of days, and then it will slowly disappear within a couple of weeks. Urticarial eruptions. So these ones basically look like hives, and they can appear in a number of different ways. So you can have confluent hives, or you can have solitary hives, even dermographism, which is considered to be a form of urticaria, pressure urticaria, or where you have scratching or friction, you can actually develop hives in those areas. And this occurs in about 20% of COVID-19 skin eruptions. It lasts again also for about a week. Often these wheals and hives are very itchy, and notably it spares thicker areas of the skin such as the palms and soles. It can often be in the symptomatic phase, so you'll see that when patients have this, they'll often have a fever and cough, and as that abates, so will the urticaria. So what is urticaria and why does this happen? We're not really sure fully, but the current theory is that we have mast cell activation, you have vascular dilatation, and when that happens, you have fluid release, not in the blister plane between the epidermis and the dermis, but within the interstitium of the dermis itself. So it causes these hives to occur, and it can be extraordinarily itchy. The reason for that is because they're pushing up against nerves that are within the cutaneous dermis. If they're below the dermis in the subcutaneous fat, what we call angioedema, usually you don't get itch because that's not where the nerve planes are. They're usually within the dermis. So fortunately with this, we don't see angioedema, which can be a little bit more dangerous, especially if you have a lot of fluid within that area, within the subcutaneous tissue, that's pushing up against vital structures, especially the trachea. So you don't see angioedema, but you can see urticaria. Here's an example of a teledermatology image. Even though it's of relative blurry quality, you can still see this relative edema, which is within the dermis. You can see that it's a little bit elevated. It has this blanchable quality in the center and erythema towards the periphery. As it grows out, it tends to dissipate. The key thing about urticarial plaques is they typically, each one will last for less than a day. So the magic number is 24 hours. It'll come up, last for about a day, then it will dissipate. and then it will come up somewhere else, or maybe even in the same spot. If it lasts for more than 24 hours, we often will take a biopsy to rule out other reasons why you'd have permanent edema within the interstitium, such as urticarial vasculitis. Very uncommon in this condition, but it is possible, and I have indeed taken a biopsy that did confirm one. Here's another example of the urticarial phase, and you can see a little bit more clearer here how you have the erythema, and then you might even have a surrounding pallor. So you notice around these plaques, there's a little bit of this white halo. That's not uncommon with urticaria, and this can actually be reduced with antihistamines. In fact, I'm going to show you, I'm going to leave the treatment more to the end, and we'll talk to you how to treat that. But right now, I just want you to identify the various signs that we see. So we've seen pseudo-vesiculation, we have seen inflammation, and now we're seeing a little bit of urticaria. Here's another example. So these nicely characterize the erythema in the center and the surrounding pallor. And again, this will be there for about 24 hours, each of these plaques, and then they'll settle, and then you might arise again. A couple of patterns are a little bit, now we're going into the more severe category. So the livedoid pattern is one of those. So in this pattern, you have this violaceous net-like or reticular pattern. Reticular means web-like, and it may be associated sometimes with tissue ischemia or necrosis, depending on how much vasoconstriction is occurring underneath the skin. And typically it's non-inflammatory, it may be thrombotic. There's a number of different patterns that you'll see, but generally it's that web-like reticular pattern. If you see this, it does indicate severe disease. In the registry data, we found that all patients who had this were in fact hospitalized, and 80% had respiratory illness concomitantly, and there was a 10% mortality rate. So here is a very poor picture that kind of illustrates, if you look a little bit distantly, the reticular pattern that is there. It's starting to, I don't know if this is at the beginning of it or the late stage of this, but that is the kind of pattern you'll see. Here is a better idea. So we've kind of enhanced the reticulation there by using different types of lighting that can enhance that for photographic purposes. And you can see this and appreciate this web-like pattern. It's very reticular. If you press your finger on it, it may blanch. And then when you release it, it may return. You may get a little bit of refill there. So this web-like pattern is due to vascular constriction and dilatation, and maybe even microthrombi might be involved there. But when you see it, usually patients are quite sick. Here's another example on the buttocks. So if you, initially it might appear like they're papular, but in fact, most of these are flat and livedoid. And we talked about ischemia and necrosis. Indeed, that can occur. This is an example of a patient in the ICU who had skin breakdown because of, I believe, vasoconstriction and lack of oxygenation to the skin surrounding the vasoconstricted tissue. Okay, petechial patterns. These aren't as dangerous as a livedoid or pattern that you see. The other term I didn't mention is retiform. So retiform means that you have a livedoid pattern, but you also have these puntate breakdown of skin within that area. So when you're starting to see that, that is more in keeping with this picture, and we have to be very acute in our treatment, and we have to take it very seriously because this can actually come up very quickly. But the petechial pattern isn't as severe. Here we do have violaceous, flat, sometimes slightly raised papules. They tend to be non-blanchable. So that means that red blood cells have actually extravasated from the blood vessels that are cutaneous near the surface. So mostly they're capillaries, they're not critical blood vessels, they're near the surface. And when you have red blood cells that escape, it'll create a little bit of papules to occur, and it'll be purpuric. But purpuric doesn't necessarily mean purple. It can also be these red papules that do not blanch. So this is called a dengue-like appearance. Sometimes we'll see it in the background setting of low platelets. And we mentioned that it's due to bleeding within the skin itself. And they're very small. That's why we don't call it purpura. Purpura is larger areas of bleeding into the skin. Petechiae is just smaller areas. So they can in fact be very pinpoint at times as well. Indicates that there's vascular injury. And there's, if you took a biopsy of this, which you might wish to do if you wish to determine that, you will see that there will be red blood cells that are extravasated, but there will also be some inflammation in around the vessel walls that have also contributed to the destruction of the vessel. And all of these patients that have this tend to be hospitalized. So we see this in the ICU. So those who are intensivists, I'm certain that you would have seen this before. Usually it's in gravity dependent areas such as the hands and feet and buttocks. And you can see very closely there will be small pinpoint areas of purpura, and then they will sometimes become confluent into larger papules and macules. Here's another example. So this patient is also hospitalized, but not very sick or coming out of an illness. That's sometimes where you can see it as well. And if you try to blanch this, chances are some of them may blanch, but most of them won't. The areas where you have the red blood cell extravasation will not blanch. Here is yet another example of that. So you can see this is on the back, and these are purpuric, but there's also a little bit of crust, which is representative of some of the inflammation has reached the surface, and it's caused white blood cells to reach there, and it becomes a little bit rough surfaced as well. Okay, acral ischemia. So this is the one that has received a lot of attention in the media. It's called COVID toes or COVID feet. What we call it in dermatology is pseudo-chilblains. So chilblains or perniosis is the other, I guess, entity that this would look like. The thing is, it's not technically perniosis and it's not chilblains. This is related to the viral infection COVID-19. The mean age of this is about 9 to 12 years, according to the registries. But indeed, I've seen this in all ages, including seniors as well. It does tend to have a male predominance, and patients may be healthy. In fact, 16% only were hospitalized when they had this. And it's interesting because perniosis is actually very common during colder months. So not really winter, but usually spring or in fall when the temperature is low, but not in freezing. It's super freezing, usually around 4 degrees Celsius to 10 degrees Celsius. Some patients will have a similar type of picture where they'll get something called chilblains or perniosis, this purple discoloration of their distal extremities, their toes, their fingers, and it can be often painful. And sometimes it can even leak. You can have a little bit of leakage and edema associated with it. And it's due, we believe, to a vasoconstriction event. So almost like a Raynaud's phenomenon, but it lasts a little bit longer, and it has an inflammatory process associated with it. Now that's true perniosis and true chilblains. In this one, it's related irrespective of temperature, although I do think colder temperatures will contribute to this as well as where it is. So if your feet are cold and your hands are cold and you have been exposed to COVID-19, then you may develop this, in fact. So swelling, itching, pain, and there's a number of different patterns. The pernio-like pattern is 13% according to the registry. There's an ecchymotic pattern, and then there's these combined patterns as well. So it's inflammation in the dermis of the skin. Again, forgive the quality of this picture. This one comes from the community, but you can see we don't need to have fantastically clear pictures. As long as we can determine where it is and get some of the features, chances are we can help out patients even remotely. So you can see that the inflammation is here. There's blood vessel dilatation. There's some edema. And the patient already has a bit of vascular compromise as suggested by the onychomycosis of his toes. Here is yet another photograph. So this one looks more like the pernio that we talked about. So perniosis, chilblains. This typically happens in super cold temperature, so not very cold, but not freezing, but cold enough that you have vasoconstriction. And if you let this be, it can often be itchy, painful, and tender, and also you might have some edema, as we're seeing here. Hands also can happen, so fingers typically, where you have smaller cutaneous blood vessels, and if they're already small, if they constrict even further, you can get this kind of picture. Now, is it related to microthrombi or now? Sometimes it is, but in most cases it's not. It's a vasoconstriction event. So as a vascular event with this immune mediation, so in this case, you actually do have elevated itchy or tender papules, so there is inflammation that's there. So let's just go through, because you might see this more commonly, I'm going to go through a progression. These are early lesions, so you can see a little bit of almost bruising, it looks like, but indeed it's inflammation that's up in the skin. There's a discoloration that's there, and then as time goes by, it might actually involve more digits. And then as time progresses, you can get a little bit of ischemia and breakdown along with the edema we talked about. So this is a 7-day progression, same patient. Okay, so now we looked at the 6 different primary manifestations. I just wanted to show you where this fits on severity. So on the left part of the scale here, we have less severe, and then we have more severe as you go to the right. And we can see that perniosis is actually less severe. So this perennial-like appearance, this COVID toes or COVID hands now, you can see can happen quite early on in severity scale. And then as you get a little bit more severe, we start to get the other forms of rashes that we saw. So the morbilliform, urticarial, that vesicular, pseudo-vesicular. And then the worst type, I think you'll agree, is this retiform purpura, where you get that livedoid pattern and then the breakdown of skin, the ischemia and the necrosis tends to be the more severe. So very quickly, I'm just going to wrap up with 2 more types of skin problems that you'll see, and then I'll take some questions. So this, and we'll talk about treatment as well, and the treatment can apply to all of these. But skin problems related to the PPE that we're wearing, as well as personal hygiene measures, there's quite a few of them. So one of them is this. So I won't, unfortunately, I'm not face to face with you to ask you, but I'm sure most of you would say that this is hand dermatitis, and you'd be correct. So it's a hand eczema due to what? That's right, it's due to the moisturizers that we use, but also the hand sanitizers that we use, the frequent drying and wetting, and then drying again. This is all related to breaking our skin barrier down and exposing us to different types of chemicals that we really shouldn't be exposed to over long term, can cause inflammatory reactions such as hand dermatitis. So this we see really commonly, and before we see it on the palms, we often will see it on the dorsal hands. It'll be a red, so erythematous, slightly scaly if it goes on for a longer period of time, more than 7 days to 2 weeks, you get a bit of scale that's there, but also extraordinary itch can be associated with this. Ultimately, you can get a bit of skin breakdown, cracking, and fissuring as well. This is an example of the cracking and fissuring that you get. So patients and caregivers, we're ourselves, we're utilizing gloves all the time. We're putting on hand sanitizer all of the time, or at least you should be. And then we're moisturizing our hands. Even some of that moisturizers can cause irritation and inflammation and breakdown of skin. And when the barrier, of course, is broken down, then you're going to get the problem compounded. So there's this cycle, this vicious cycle of inflammation and skin breakdown and inflammation again. And over time, even the treatments that we use, the cortisones that we use, and the anti-inflammatories can also contribute to the problem. I'm going to show you at the end how to treat this more appropriately so that that doesn't happen, and hopefully the process will stop. Here we have also a dermatitis. So this one is happening on the face. And so this patient was sent to me by a rural family doctor. And we believe that it was related to not only things that have been applied to the face, but also, that's right, masks. So the masks that we use, as important as they are, can sometimes cause issues to occur. So not only do masks change the environment, the humidity environment, they also trap in the air that we breathe out. So carbon dioxide air is believed to be an irritant. By itself, it can be acidic compared to the general atmosphere. So that is believed to be a notable cause. Plus, it can also trap in other things, makeup, bacteria, moisturizers over longer periods of time can even prevent the skin from breathing, and even your own sweat can be an irritant, believe it or not, and can cause a picture like this. So this patient has inflammation. You can see the poorly demarcated, red, scaly, probably itchy plaques on the face, and this is very typical, what we call a facial dermatitis. Now, what about this? This isn't quite a dermatitis, but you can see the area where the patient's been wearing a mask also happens to be a hormonally dependent area, meaning there's a lot of progesterone and other hormone receptors that are in the lower part of the face on the angle of the jaw and the jawline. You can see that she has some comedones. These are whiteheads and blackheads. So they're representative of dead skin material keratin that has been trapped by the pores that are there and made worse by the mask. And in a female, we often have more hormonal influences in that region. So this is acne vulgaris. You can call this hormonal acne, or some people call this mask acne, or maskne is the term that's very popular. It's a buzz phrase. And I'm going to show you how to treat that. Even if you're not a dermatologist, there's a number of things that you can do that will help to keep this under control. Now, this is very different. This isn't traditional acne, but it's something that we do see exacerbated with mask wearing. This is called periorificial, or in this case, perioral dermatitis. It's neither acne nor is it a dermatitis. It's actually a combination of the both. You can sometimes have an eczema-like picture, and sometimes you can have this inflammatory acne-like picture. The name periorificial means it's around an orifice or hole in the head. So it can be around the mouth, it can be around the nose, it can be around the eyes. And the trick in this case is to avoid corticosteroid usage, which is often the tendency. Our first knee-jerk reaction, something's red, put cortisones on it. Well, it's not going to work in this case. It may help temporarily for a few hours, and then you're going to have a rebound where things will get far, far worse. So please avoid that, or at least consult with us and we'll be able to help you out a little bit more. There's a bad rebound phenomenon with cortisones and perioral dermatitis. Instead, there's alternatives that we can tell you. We'll talk about that in a moment. And sometimes we even treat it with antibiotics as well. Not necessarily for the antibiotic potential of them or antibacterial potential, but more for the anti-inflammatory potential. And I have found some good success with that. Now, finally, just a few skin problems related to COVID-19 management. So this is the same patient that had been that presented with a rash related to a very specific medication that I don't think we use specifically for COVID, but in the earlier days when we're figuring out how to manage some of these signs and symptoms, people would use this one. This is a Plaquenil related rash, or hydroxychloroquine related rash. And it was you can see that different rashes will exhibit a little bit differently. Some of them will have some degree of photosensitivity, as this one tended to have. But the general thing is a temporal correlation. So if you're starting to see the rash, usually it's at the time that you're giving it, or even after second exposure to it is probably more common. We start to see these widespread rashes, and they're related to medications. So I've seen it with hydroxychloroquine. I haven't seen it with other medications related to this, but that doesn't mean it can't happen. It probably could. People are talking about ivermectin being used to treat the symptoms of COVID-19. Ivermectin is not readily available in Canada for humans anyway, other than in topical form. We do have one, but orally it's hard. But if they do get it, it's had in the past has been associated with a lot of rashes. So we might see that in the future. Now, what about immunization-related rashes? Well, I've only seen one, and I do think it was related to the immunization. But you know what? That doesn't mean that that people shouldn't get immunized. Indeed, it's usually a mild thing if it does happen, and we see it with a lot of immunizations. You see it with pneumovax, you see it with the flu vaccine. People get this morbilliform rash that's usually not very severe. It might be itchy at most. It'll look a little bit bad, typically on the trunk, mostly on the extremities, especially on gravity-dependent areas. And then it tends to go away just as quickly as it came. So usually it's within a couple of days. It might last 1 or 2 weeks at most, but we can expedite its resolution using a number of different interventions that I'll talk about in a second here. So what are those interventions? Well, for medication and immunization-related rashes, I'm going to share with you what I typically will give. And it doesn't mean that it always will work, but if you wanted to start out doing something very safe and effective in most cases, this is something that I'd like to share with you. So there's a topical mixture that most of the dermatologists who studied at the University of Alberta have used for ages, which I'm going to donate that to you, share that information. It's a little bit of menthol, 0.3% menthol in either Elicom or cyclocort cream. So it's a mid-potency corticosteroid, and we mix it 1/3 with a moisturizer. So we used to give Aquaphor, but then Aquaphor was shorted, and so I've switched it over to Glaxol base. And so when we give it in that ratio with a little bit of menthol, it reduces itch, and it tends to reduce inflammation for these types of rashes associated with medication immunization. And I say apply up to 3 times daily. One of those times should be after showering or bathing, and it works very well to reduce the inflammation and itch. The second thing is antihistamines, and there's a couple of antihistamines that are newer, second generation ones that don't have many side effects at all. They're very, very safe. The drug-drug interaction is very minimal. One of them is called Rupatadine or Rupall. I like that personally, specifically for immunization and medication reactions, because it has this antiplatelet activating factor, which theoretically might reduce inflammation as well. So Rupatadine is normally the dose would be 10 milligrams a day, But I'll tell you, if you give patients 10 milligrams a day, it's not really going to work that well. So I've actually changed this to meet certain guidelines that are global that work even better. What I would suggest is that you take it and you quadruple the dose. And that sounds so crazy. And a lot of pharmacists, they really get scared when we write that. And I always used to get a call, "Are you sure?" And I tell them, "No, I'm absolutely sure. It's very, very safe and effective. And in fact, it's necessary in many cases." So what I'll do is I'll do 2 pills twice a day. So that's 20 milligrams BID. And typically I'll write it as 30 days or until their lesions improve, whichever comes first. And then when that happens, then they'll go down to the indicated dose of 1 pill a day, which in this case is 10 milligrams a day, for an additional few weeks, maybe even for another month. And I tell you, patients love it. It works extremely well to reduce itch as well as any kind of urticarial-like response associated with not only medications, immunizations, but also the urticarial rashes. Finally, I give them a hydration protocol. So we find that water is a natural fire extinguisher of inflammation, and it will help to reduce the inflammation, maybe even enhance some of the other interventions that you're having. So I am going to share this with you, actually. I'll give you a QR code and you can download this. This is something that I created over the past year with the help of several companies, so it's very non-biased. And I give it to all our consult derm physicians who need this for their patients. So I got 2 of them for you. I got a dry skin eczema skincare protocol, and it has a number of different choices of great, inexpensive, bland moisturizers to help to lock in any fluid and also barrier protect the skin, allowing the skin to retain its barrier and maybe even grow that barrier, thereby preventing further rashes from occurring. I have one for dry skin eczema. I have another one for mild to moderate acne, but I also use it for anything that's on the face because these moisturizers are less viscous and they don't cause outbreaks and other problems. So let me just summarize a few things for you. Managing COVID-19 and the skin. So these are lab abnormalities that the AAD registry has found to be abnormal in many patients. Now, do we routinely do this in dermatology for when we see a skin rash? No, but I bring it up just more as an academic point. You may wish to look at this, and depending on the subspecialty you're in, it may be more relevant. But these indeed are what the skin doctors with the AAD have found have been abnormal. Now, I'm going to show you what I think is very important and practical. So if you do see a skin rash, this is what you should do. First of all, we have to recognize that it's a skin rash. I would consider COVID with any new onset rash during the pandemic. And then we have to determine, is the skin problem associated with the infection itself, or is it something else? Is it due to our intervention perhaps, or something completely different? So if you see something like that, do consider it. And then work up. So, these are all, when you read the literature, and I went through a literature search over the last few months. I actually presented something similar to this at the Rocky Mountain Internal Medicine conference a few months ago. So in doing so, they talked about PCR and all that. That's not really practical. Would you really do that? No, there'd be other testing. Because as we mentioned, most of these things, other than the retiform purpura, usually are self-limited. They'll go away within a matter of a few weeks. Antibody testing, not really indicated, but they do mention that in the literature. The prognosis is usually really good with these rashes, self-limited in a few weeks. We really want to keep patients comfortable and also mentally stable as well. So they can be dying from respiratory illness, but what can be bothering them is their acne, right? So we want to make sure that we keep them as happy as possible. So how do we do that? Well, most of it is supportive. Number one, topical corticosteroids for the inflammatory process, or if it's on the face or thinner areas, we have steroid substitutes. We talked about a little bit, we hinted towards that. I'm going to show you exactly which ones I use. Number two is antihistamines for urticarial eruptions. That makes sense. 3 is the treatment of sequelae and management-related side effects. And then 4, if you want to, we're always available for you, referral to dermatology. We'll talk about how we can do that. So first, topical anti-inflammatory therapy. So for the face, which has thinner skin, the neck, thinner skin, and skin folds, you could use cortisones, but I would suggest that we limit it. So use it, but limit its usage. So you want to use low potencies of corticosteroids on thin areas. So I've given a couple examples. There's hydrocortisone 2%, which is prescription, or you can use Desicort to Desinide. These are my favorites. I like to use those, but only for a short period of time. Typically, I'll use it for twice a day. No problems doing that. To the affected areas only. Do it for 2 weeks with a couple of days break. So maybe 2 weeks on, 2 to 3 days off, and then repeat as needed. Now, if things are relatively under control or not very inflamed, what's recommended is non-steroidal substitutes. And there's 3 that are available in the market. There is Protopic, which is topical tacrolimus. There's Eucrisa, which is topical crisaborole or crisaborole ointment. And there's also a cream calcineurin inhibitor, which we call Elidel, which is pimecrolimus. I didn't have enough room to write pimecrolimus, but that's what that is. So tacrolimus, crisaborole, pimecrolimus, these are all very, very safe to use on thin areas. They won't thin out the skin further. They will, usually they're very, very safe. The adult percentage of Protopic is 0.1%. If it's under the age of 12, then it's 0.03% ointment. For the trunk and extremities, you will need the potency of a higher potency corticosteroid. So these are some that I commonly will use. Elicom or mometasone, Betaderm, which is betamethasone, and cyclocort, which is amcininide in cream or ointment. Generally, if it's atopic dermatitis or eczema disorders where your barrier is compromised, people like to use ointments because they feel a little bit more soothing. They also don't have as many preservatives with which to interact with the skin, so they usually don't cause things to become worse. For really thick areas of skin or palms and soles, you need a higher potency corticosteroid, and I wouldn't go with a cream at all. I'd go with an ointment because ointments head-to-head compared to creams will actually penetrate better. They will cause a higher potency effect, and so the ones I like to use are either Ultravate, Temavate, or Halog. So that's halobetazole, clobetasol, halcinonide. Different dermatologists might have different preferences. These have always worked quite well for me, so I would pass it on to you. Finally, what about hair-bearing areas such as the scalp? These are a couple of examples. There's Clobex, which is clobetasol spray. Often patients like that for inflamed areas of the scalp. And there's also a scalp oil that I like to use called Dermasmooth FS. And you would prescribe that. Typically, it's about 60 mils to 100 mils. Just put one tube in, or one bottle, and the pharmacist will figure that out for you. I talked a little bit about this anti-itch cream that I've been using since I was a resident in dermatology at the U of A. This one works quite well in most cases. It's a good starting point. And then anything that's remaining, you can either, please feel free to consult with us, or we can try a more potent preparation. This one works quite nicely. And then I'm going to share with you this anti-crack cream, which is a really good formula for cracks and fissures of the palms and soles. And I used to call it the crack cream, but then that was misconstrued to be other things. So now I call it the anti-crack cream. And it contains a little bit of silver nitrate with salicylic acid and Vaseline. People take a Q-tip and they apply it to the cracks, and it works like a charm. It seals it with this little caveat that it might temporarily discolor the skin black, not necessarily in the area that you affect, but in other areas where it might just come into contact inadvertently. And that may take a few weeks to resolve. I do tell patients that so that they're not scared when they see these little black dots, but it's just a temporary phenomenon. It'll go away. Okay, so here is the dry skin and eczema hydration protocol. Please feel free to take this one. This one is made by a number of different companies I worked with, and it is very, very good. And it's very comprehensive, and it's not biased. And finally, oral antihistamines. So we talked about rupatadine, second generation antihistamine. There is another one I also like very much called Blexten or Bilastine. And Bilastine is normally 20 milligrams a day. That is its indicated dose, its prescription. And that really doesn't work at 20 milligrams in most cases of urticaria. You usually have to go a little bit higher. And there's lots of studies and empirical evidence and guidelines that suggest that you go higher, even 4 times the dose. And when things are good, you can drop down. Finally, anti-acne therapy. So if patients have comedonal acne, mild acne, comedonal acne, or even inflammatory acne, these are some suggestions. We've got 2 combination agents, one called Biacna, another called Tac2 Pump, which work quite nicely. It's a good starting point with the caveat that these are all gels, and then you must moisturize, otherwise they're going to go ahead and be quite dry. Axone gel is a very good low molecular weight dapsone gel that can penetrate, especially if you have hormonal acne, lower facial, it works quite well. Remember, for perioral dermatitis, no corticosteroids. Use one of those cortisone substitutes like Protopic, Eucrisa, or Elidel twice a day until it's resolved. And here's the trick with perioral dermatitis is you don't stop, you'll go twice a week. So less frequent for an additional 8 weeks for maintenance has always worked very well for me. Sometimes we have to add an oral anti-inflammatory antibiotic combination. So doxycycline 100 BID or minocycline 100 once a day for 8 weeks will often work quite nicely. Feel free to download this. This is the mild to moderate acne skincare regimen. And if you want this, of course, if you didn't capture it now, we can send this to you. It's very easy to do. Finally, when to refer to a dermatologist. If you need diagnostic assistance, of course, if you want to have a biopsy performed or even our eyes to take a look at it, we'll be happy to do that for you. Management assistance for primary problems or even the treatment sequelae, we'd be very, very happy to do that for you anytime. I want to do a quick plug for Consult Derm. It's consultderm.com, available to any physician or a nurse practitioner in Alberta. We have 12 dermatologists that are ready, willing, and able to serve you anytime. So with that, I think I've taken up a lot of your time, but we have a few minutes for questions.
Thanks, Jaggi. That was outstanding. Just really quick, there was a question in the Q&A about whether or not you recommend biopsying any of these lesions for a diagnosis, or I mean, obviously, if you're suspicious, you're going to do an NP swab, but is there any role for biopsy?
You know, the purist would say yes, but practically I would say no. In most cases, no. I mean, most of these things are self-limited, and often by doing a biopsy, you might actually create a problem where there wasn't. So I would say, you know, in most cases, no. We can, like all of the ones I showed you were eyeballed, and ultimately we didn't have to do a biopsy. If it was more serious, they're in the ICU, and you know, we need to find out exactly what's going on. Is it calciphylaxis? Is it a retiform purpura that's become ischemic? Then I most certainly would.
And then just another question around, you know, we know there's two phases to illness in COVID. There's that primary phase, right? And then the likely worse secondary phase, which is predominantly inflammatory. Are there any lesions, skin lesions that help sort of correlate with primary versus the secondary manifestations, or you know, is there a way?
Yeah, good question. I think that the vascular, when you start to see those vascular events, then that is more primary. The inflammatory can happen more secondarily, but you know, there's a little bit of an overlap because the skin is so full of both of these different processes.
And probably not enough information yet to really know, right?
I think so.
Last question just came through in the chat about, do you recommend a COVID swab for otherwise asymptomatic patients with pernio or pseudopernio?
Yeah, I think it's a good idea. I think of the skin manifestations as a symptom. So even though we say they're asymptomatic, well, you know, think of the sign as the symptom, if you will. And it's not a bad idea to find out, because of course, if they do have it, they might spread it to other people. So by identifying it positively, we might be able to do some social distancing, social isolation protocols.
All the public, just from a public health perspective, right?
Correct. Yeah.
And,
right.
and with the rapid testing now, you know, we are getting results much quicker. So, and then last question is, some of those preparations that you talked about, are they compounded, or are they available sort of pre-mixed from the pharmacy? How do you
That's right. So the ones that are trademarked, and I'm happy to give you this presentation so you can look at it again, but the ones that are trademarked are all available commercially. They don't have to be compounded. The only ones that have to be compounded is that itch mix and that anti-crack cream. Otherwise, they're all commercially available.
Perfect. And then the last question is, I said last one's last, this was the last one.
Oh, no problem.
If the COVID toes are symptomatic, like painful or itchy, is there any specific treatment that you would recommend?
Yeah, I would start off with that itch mix that I gave. So that's a really nice one, because the menthol, as it evaporates, it'll cool the skin down a little bit, but not enough that it'll make the problem worse. In fact, it'll reduce inflammation as well as the symptoms associated with it.
That was fantastic, really practical, and thank you so much. It was
my privilege. Thanks again for having me.
Okay. Next week, we're going to have a discussion around sort of resiliency and leadership around with everything that's going on. Dr. Deborah Wet-Wartsville is going to be presenting, so hopefully you'll all come in and have a great weekend. Thank you.
Be safe.
Be safe.